We continue now with our Musculoskeletal Ultrasound course, focusing on the shoulder anatomy segment. Now we're going to talk about the rotator interval. The rotator interval is this anterior part of the shoulder, which is bordered by the superior edge of the subscapularis, the anterior edge of the supraspinatus, and forms a triangle with its medial base at the coracoid. It contains the long head of the biceps as one of its main elements. However, it is an anatomical segment that contains many more structures, since there's a part of the capsule, as well as the superior glenohumeral ligament and the coracohumeral ligament, along with the bicipital groove. Let's look at it in more detail, because this structure is important. Source of pathology and interventions. So our rotator interval, as we already mentioned, with its boundaries being the superior border of the subscapularis in blue and the anterior border of the supraspinatus in red, contains the biceps. But we've also talked about how it contains the articular capsule in the superior and anterior part, the superior glenohumeral ligament and the coracohumeral ligament. All of these ligaments are integrated together. They are also part of what is known as the transverse humeral ligament, and there are publications that refer to the anterior and superior ligamentous complex of the shoulder when talking about it. This is the easiest way to find and study it. There are also references to it as the Gordon-Brody ligamentous complex, but we prefer this name because of its simplicity and ease for ultrasound study. So we can evaluate it in a position we already know, which is the Y position, and the ultrasound probe will be in this position, almost as if we were evaluating the supraspinatus in the short axis. We will start from our knowledge of the anatomy in order to recognize it on ultrasound, and we will identify all these structures that I have already mentioned, where the most important thing is to be able to identify the capsule and the superior glenohumeral ligament, and the pillars of the bicipital groove, which we will be evaluating shortly. So once again, our anterior and superior ligament complex of the shoulder, previously known as the Gordon-Brody complex, basically contains the biceps and is the main structure we will reference when viewing the ultrasound, along with the subscapularis and supraspinatus. With these three images that we are able to identify, we will then be able to identify the rest. So let's take a proper and correct look at how we're going to position our probe, and you'll see that it's very similar to the position used to study the coracoacromial ligament. That is, we use the coracoid as a reference, then rotate it about 30 to 45 degrees, and we will visualize the coracohumeral ligament. We move laterally, and this is the trick to learning how to see it. At the beginning, this is a good sequence. So it's practically the same position we already studied for the coracoacromial ligament, except that we're going to move a little more laterally, and then we'll be able to get this image, which is always a constant when we're studying it. I want to highlight here that these images, so rich in definition and detail, are supported by literature that we're discussing. This is a beautiful study from the Japanese group led by Dr. Mochizuki, where they really show us how the superior glenohumeral ligament, which stabilizes the biceps, forms this hammock. So depending on the position where I place my probe, I may or may not visualize this superior glenohumeral ligament. The histological section, as you can see in the study I'm mentioning, is very, very similar to what you can observe depending on where you're evaluating with the probe. Basically, you'll find it wrapping around the biceps, and let's look at it here in a more schematic way. In a more academic way, this is the image of the deltoid that we already know how to identify for the interval, in the position I just mentioned, the anterior border of the supraspinatus and the superior border of the subscapularis, and in the center, the biceps. So we are going to clearly identify the capsule and the superior glenohumeral ligament, which takes the shape described by the Japanese group. Let's take a look. In greater detail, don't forget that the placement of the probe is the most important thing for both intervention and diagnosis in this segment. Let's go over the main structures again. Remember that when we are evaluating, we already know how to read the ultrasound, and we are going to interpret whether there is, as in this case, hypoechogenicity or hyperechogenicity, according to the position of our probe. Identification of the ultrasound signal. The key anatomical structure is bone, with a posterior acoustic shadow and a hyperechoic image. We will also see tissues that we have already identified, tendons, which are rich in fibers and have little water, which is why they are very hyperechoic. So knowing this and the anatomical segment, let's do the ultrasound. Basically, it is possible to identify each of our structures. If we focus on the biceps, we can see the capsule, the superior glenohumeral ligament, and we will also identify the two pillars with expansions of the coracohumeral ligament, just as we do in an arthroscopy. This is an ultrasound of the rotator interval. Let's look, for example, at adhesive capsulitis. This is an ultrasound for treatment in interventional procedures, which we will see later. But if we clearly reference where the pathology is, which you already know well, and there is a lecture about it, we can perform the intervention at the level of the capsule and the ligament, which are the areas that clearly harbor pathologies like the one I just described. We'll cover capsulitis of a lecture. Rotator interval, a sonoanatomic structure to study in our module.